Oh, interesting question. So the perspective I'm trying to bring today was very much a hospital perspective, an acute NHS trust perspective. What is our challenges as a system in terms of performance, in terms of choke points within that system, and what kind of digital health is useful in us meeting those challenges. And then the next question for us is basically what are the barriers to adoption? What stops us taking those opportunities at a local level? And lastly is what does it mean at a global level for UK PLC, the NHS as a whole, and our sort of global place in the healthcare market, and what are the opportunities? So I think it was really useful because the first thing I learned was our challenges in the NHS are very similar to the German system and many other Western European systems, so we're not unique. So if we're not unique, then the kind of digital adoption and spread we need is similar. And if we have standardization, then we are more likely to produce solutions that give investors a return on investment, which mean that they're more likely to happen because the healthcare system is not designed to invent new digital health innovations. That's really the marketplace, that's really entrepreneurs, that's really collaborative ventures with healthcare actors like ourselves, with large providers, large telcos, and imaginative people with new ideas. If you're going to bring that together and they're going to succeed, then you need standardization, because only standardization can ensure you have market access. So if I made a device just for, say, my region in the UK, it's not likely to be commercially successful because the marketplace is too small. But if we can standardize firstly at a local level and then standardize at a European level, then we have a sustainable marketplace. So some venture capitalist now sees that my invention is likely to produce a return. And that's simply why, if you have, say today, the same idea marketed in the UK and then the same idea marketed in the US, the company valuation has a 12 times difference. And the 12 times difference is purely down to market access. Now, I think really in the UK and Western Europe, we have a lot of expertise in life sciences. We have a lot of expertise in digital technologies. So we have a huge opportunity to create the next Google or Amazon for digital tech. A lot of the 6G and slicing standardization issues will be solved by government and the telcos. I think there needs to be a social contract and some sort of an agreement with the patient cohorts and the healthcare providers around the patient health record. And I think governments and the tech industry will work on EID. So the three, so if really digital health was a stool or a table, if it was a stool, there would be like three things: ID, patient health record, advanced networks. If you're going to turn it into a table, then you need patient participation in essence, and that turns it into a stable table. If you have all four, you have the potential of market-leading solutions that you can export into emerging territories like India, Middle East, Africa, which are going to be the fastest growing healthcare markets in the world. The question is, can we or do we have the political will to get the standards to converge in a timely fashion, that these technologies become enabled? So the problem that you have in all Western health economies is you're going to have less hospitals for a number of reasons. One is affordability. Hospitals are really expensive to operate and maintain. Secondly, workforce and expertise. And then thirdly, basically, there is no reason for everybody to be in a hospital. A lot of healthcare can be delivered in the home, it can be delivered in the care home, it could be delivered in the community context. So if you're doing that, then basically hospitals become reserved for shorter length of stay episodes, specific episodes of care. So you might come in for elective treatment. And then once you've had your elective treatment, you are discharged and managed remotely in the home. So one of the things that we've done in the NHS is we spent billions and billions of pounds. We've actually doubled the health budgets in some instances. And one thing that hasn't happened is we don't have more productivity. We actually see less patients now than we did 20 years ago, but we spend double the money. So the money is not the answer. The answer is how you create capacity. Yeah, and the challenge there is you need to get primary healthcare right, you need to get on the back end discharge processes right. So the only way you can do that is if you have a lot of people coming in for elective processes, you need to make sure that that elective episode of care is effective, efficient, and everything comes together. And there's going to be less complications because he's in a fit position to effectively have that surgery. It's also saving me time. It means that he's not going to get rejected for surgery, which means I'm not losing an operating theatre slot. At the moment, 1 in 8 slots are lost in my hospital, which is a waste of money. And it's bad for my patients because the patient that could have surgery has lost that ability, right? So remote health at the front end is useful. Remote health in the back end is when he goes home, I want to make sure he's doing the exercises, right? Because only then you will get well. So you need that's personalized health. So that's creating capacity at the back end. But at the same time, Theo needs to feel comfortable that if he needs medication for his pain, he can call for that through his device. He doesn't need to go into hospital. Now, coming into hospital is a horrible thing for patients to do. I'll tell you why. Because hospitals are full of infections. And 7% of my attendees in my hospital have a hospital-acquired infection. So up to 20% of my bed base will potentially be occupied by people with hospital-acquired infections. So one of the ways that I will do that is by, if I have a hospital for knee operations, my theatre will do thousands of knee operations. Now, in order to make that work, I've got to ensure that you trust the care that I'm offering. That care is of high quality. And what I mean by high quality in health, quality in health means reduced patient risk, improved patient experience, and improved clinical outcomes. That's the definition of quality. So we always need to be mindful that if we're replacing a hospital bed with a remote bed, that these criteria are met, and you as a patient must trust that. The other thing that I worry about is healthcare doesn't become accessible to only people with digital devices. That we don't discriminate people upon their ability, on their race, on their gender, on their capacity. Generally what happens in healthcare is if you're middle class and you're well educated and you're wealthy, you write a lot of letters to the hospital administrator, me, right? And you sort of say, I need my knee operation urgently. Whereas on the other case, there may be somebody with a chronic illness or a severe illness that needs to be prioritized, but they don't write me letters because their first language is not English. So am I going to prioritize Theo's knee over somebody who's a more urgent case, but they're not speaking up? This is a big question with digital health, is the digital divide and health inequalities. To me, that's really a concern. But if I say, as a regional healthcare provider, I'm going to shut this hospital down, you will have a political movement. Everybody will write to their member of parliament saying, we need this hospital. We need the budget to be preserved, even if it's inefficient. So I think really that's a challenge, and it's a political challenge to manage. And you have to convince the voters and the electorate and the constituents to trust the alternative arrangements that you put in place. And that is only going to happen is if you can demonstrate it's better than what they have already got. So the problem is, if you live in a remote rural area and you take that hospital away, is your voice disappearing in the health system? Do you still have a voice, right? Now, it's what safeguards you put in to say that I can still have the same quality of care. So if you turn around and say, well, you can have that care episode shorter in a different city, but we will actually finance the ability for you to come back home, and we will ensure that you have a field nurse or you have access remotely to basically manage your recovery, then people are more accepting. So if you say to people, okay, we close this hospital down, but you only have remote control care, you will only see a screen, you will only see a mobile device, they won't accept it. If you say you have a screen, but on that screen, I can press a button saying my knee is very painful, I need to see a nurse, and that nurse physically comes to my home as a reassurance, I will accept that then, because my care pathway is not diminished. In the UK, it can take me 20 minutes to an hour for an ambulance to get to me because of availability, traffic, there might be an accident. So I've lost my 20-minute window. What is more effective is if I can have a local responder that has my clinical records, so he can intervene and start giving my treatment in the ambulance, and that you can only get through a connected ambulance. So providing my village has a connected ambulance, then my hospital can actually deliver the same quality of care in the hospital in a shorter time. So I'm actually reducing that time to treatment, not increasing it. So it's the architecture of that emergency care which is important. Well, we have the technology to do it. It's a political decision now as whether we invest in it, persuade people to accept it, close the hospital, move the resources to a connected ambulance through GP preventative services and follow-up services and social care. So I mean, I'm going to use a phrase which I've heard a lot in government circles in the UK, is at the moment, in the current level, healthcare is reactive. We need to make it proactive, right? And as long as our posture changes, that's fine. At the moment, all our finances and efforts are in accident and emergency departments reacted to things that happen. If I'm proactive and I intervene you with your heart issue before the heart issue actually happens, because I change your lifestyle, change your diet, take away the stress in your life, then you're cheaper because you're going to be well longer, you're going to cost my health system less. So it's actually moving to that new health delivery architecture that's important.